The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss keeping a focus on function. My name is Antoinette Tu, Program Manager here at the American Brain Tumor Association, and I'm delighted to introduce our speaker today, Dr. Sam Shahpar. Dr. Sam Shahpar has dedicated his career to changing the culture of cancer care. As a physiatrist leading the Cancer Rehabilitation Program at the Rehabilitation Institute of Chicago, RIC, he has extensive experience in assessing and treating cancer survivors of all diagnoses throughout their continuum of care. Through RIC and his association with the Robert H. Lurie Comprehensive Cancer Center of Northwestern University, Dr. Shahpar helps cancer survivors thrive through functional restoration and fitness. Thank you for joining us, Dr. Shahpar. You may now begin your presentation.
Thank you for the introduction, Antoinette, and I will be moving forward. We'll go through a wide variety of topics today that will hopefully take it step by step and hopefully answer your questions, any that you have, towards the end. So first step, as Antoinette mentioned, is title of the talk today is keeping a focus on function, and really from my aspect, function is how I look at all patients, and we'll go through this detail by detail. My first slide, just to let you know, I have no disclosures to state before getting this started, and we will jump into our objectives. For my first hope, I would hope you guys take away my goal of defining what the physiatric role in patient care. So I'm a physiatrist, as Antoinette mentioned, so understanding what a physiatrist does and how we integrate into patients' care. And hopefully we have some increased awareness of the unique functional issues facing brain tumor survivors and understand the comprehensive nature of cancer rehabilitation throughout this continuum of care. So first up, as I had mentioned, is what is a physiatrist? A physiatrist is a physician specialist in physical medicine rehabilitation. You may have heard the term PM&R, or rehab doctor, or physiatrist. There's a lot of different names people go by, which leads to some of the confusion. But really our focus is we're a medical specialty emphasizing the prevention, diagnosis, treatment, and restoration of functional loss produced by medical, surgical, illness, or disease process. We really look at the function of the whole patient, and by focusing on function, we may look at different aspects. Even though a patient may come to me with a specific problem, in order for us to focus on function, we need to look at the big picture on a whole. So as some people may recognize our specialty in the field, you can see on the current slide, this was Senator Mark Kirk here in Illinois that had a stroke and was seeing a physiatrist and got rehabilitation care. Some of you may recognize former Superman Christopher Reeve, who subsequently had a spinal cord injury and was seeing a physiatrist and had rehabilitation care. And a few other faces that were in the news regarding rehabilitation care is Gabby Giffords, who looks much different now in her course of recovery, is in this bottom left part of the slide, and she had a brain injury due to a gunshot wound. And this gentleman in the upper right, his name is Jesse Sullivan. He was in the news approximately a decade ago as he's the man with the first bionic arm, so related to amputees. As I kind of highlighted here, most people don't hear about cancer patients and brain tumor patients and how they relate to it. So oftentimes we treat patients with amputations, an injury to the spinal cord, an injury to the brain, stroke, musculoskeletal injuries, so that may be arthritis or sports-related injuries, pain, cardiac disorders, neurologic syndromes. But many patients with benign and malignant brain tumors can benefit from our care and our expertise. And we'll move into where to start. What does this mean for patients who are undergoing this process? So my where to start slide. So according to the National Cancer Institute and National Coalition for Cancer Survivorship, a cancer survivor it starts from the time of diagnosis through the balance of his or her life. As we've become better at treating cancer with more focused surgery and radiation and different clinical trials and immunotherapy, our balance of life has been increasing. We're becoming better at treating the cancer, but we're not necessarily been set up clearly as patients move along this course of spectrum of treatment and recovery and trying to get back to life, of who really manages and helps the patients and their families guide through this process. So when we look at issues that patients may face, There's short-term effects, such as if you take a medicine, it may make you ill or nauseous and give you side effects that generally are short-term while you're taking it or soon after taking the medicine. Long-term effects are persistent. They often begin during treatment, whether this is radiation or chemotherapy or even surgery, and continue. A classic example used in our cancer survivor population is neuropathy. Some people take chemotherapy and they get neuropathy during treatment and it hangs along. Late effects often come along long after treatment. The part that we see commonly for late effects may be radiation. So during radiation, we may have side effects, we may have some long-term effects, but sometimes moving down the line a year or two or even later, we may see effects from prior radiation due to the nature of how the radiation works and continues to damage the body. These late effects we're learning more and more about. As we mentioned, the balance of life is increasing, so as people survive and live longer, we are now noticing things that may have happened to their prior treatment and things we need to recognize to focus on, one, to try to prevent, and two, to try to help if they suffer these side effects. When we focus on rehabilitation, we need to look at different aspects of survivorship and the experiences. Everyone is unique. So two people may have the same type of cancer, may have the same type of treatment, may go through the same protocol, may even be the same age, but we're all different. And we need to kind of take that context in account. So as we move through, we want to look through the disease itself, what type of cancer or tumor, where is it affecting, so what part of the brain for brain tumor patients, treatment specific, what type of surgery, what type of chemotherapy, hormonal. Now there's more immunotherapy and radiation, but there's also the individual specific. So even before the diagnosis, even before they became into our system as a cancer survivor, how was their medical status or their functional status? Were there any stresses from a psychological or social standpoint that we need to pay attention to? And that includes, are they a caregiver for another family member? Are they an active full-time worker? Are they a police officer? Are they a grandmother who's taking care of their grandchild? So all those pieces are important to us as we identify a plan for function to see what their baseline was and where we can manage and treat the issues that we face related to the disease and the treatment moving forward. So when we talk about rehabilitation or cancer or brain tumor rehabilitation, how I like to think about it is it's any evaluation or intervention assisting in the restoration of maximal function and ability in any patient with cancer or brain tumor at any point along the disease continuum. Often I'm asked, at what point should we involve rehabilitation? At what point is rehabilitation a good idea, or therapies, or seeing a physiatrist? And if we look at this definition, or at least my approach is, I don't think there's a wrong answer to that. If we're asking the question, then most likely rehabilitation care can be helpful in this process. So when we talk about rehabilitation and the approach, I really like to highlight it's an integrated team approach. And most people who've gone through the system dealing with themselves or a family member or someone they care about, they've known about this team approach. In the oncology team, they're often seeing a medical or neuro-oncologist, a surgeon, a radiation oncologist, maybe other people on the team, such as a dietitian or a social worker. So we want to integrate with that team as well as everyone else that you see around here, from a rehabilitation physician, which is a physiatrist, our physical therapist, psychologists, sometimes we involve pharmacists, we have occupational therapists and dietitians, and really the idea is the focus is on the patient, their family, their support system, to how we're trying to focus it on, and really getting rehabilitation at the best is when everyone is working together. So when we want to just get a scope of the broad spectrum of what type of unique issues we face and why is it important that we pay attention to these as we increase survivorship, I think it's nice to highlight these numbers that have come out. Every year or so, the American Cancer Society comes out with numbers based off their collection of data. These numbers are usually about a year or two behind just based off collecting the data. But as of January 1st, 2016, there are over 15.4 million survivors of cancer in the United States. And it's expected in about a decade, and now less than a decade, January 1st, 2026, they're expecting over 20.2 million survivors in the U.S. So obviously these numbers are increasing. When we speak of brain tumor patients, currently there's almost 700,000 brain tumor survivors in the U.S., and that includes primary malignant and non-malignant brain and CNS tumors, which is central nervous system tumors. In 2016, it was estimated that over 77,000 new cases of these came about in the U.S., and you can see on the bottom of the breakdown. So obviously, compared to some other cancers, the numbers may not be as high with brain tumor patients, but still looking at these numbers, they're still quite significant, and makes us, from a medical perspective, from my physiatry perspective, understanding that we need to focus on function for this patient population because it's growing and something that's going to affect all of us. So some other details that we pay attention regarding brain tumors: it is the most common cancer for children and teenagers from ages 0 to 19. Metastatic brain tumors are the most common type. They're most commonly from lung and breast cancers as the primary cancer. The most common of all malignant brain and central nervous system tumors is glioblastoma, which is a little under 50%. And of all non-malignant tumors, it's meningioma, which is over 50%. So even though, as I mentioned, that incidence is small, so if you compare it to the numbers of patients who have lung cancer or breast cancer or colon cancer, it can be a source of significant functional impairment due to where it affects. So obviously our brain controls a lot of parts of our function. So if we have damage to our brain, it has a significant effect. So oftentimes, patients with brain tumors, a higher percentage of patients may have functional impairments versus other patient populations. The exciting part is there is a potential for many of these patients to not only require but benefit from rehabilitation services. And we'll go through some of these details of how we've identified this moving through the history in terms of research and where we are currently. So going back to 1978, Dr. Lehman and her colleagues out in Seattle, they screened 805 patients, and by screening I mean looking at a chart and assessing them. They identified the rehabilitation goals, and they reviewed the hospital chart, and they performed an interview and physical exam. What they did within these patients is identified and developed optimal rehabilitation programs based off what they found, and then compared that to actually what they got. And I apologize to anyone for the slide. Unfortunately, because it's an older journal, that does not come out as clean, and I had to photocopy this picture. But if we look through the different types of cancers, and we look at these are the numbers of patients they saw. Nervous system would include the brain. Sorry to highlight this. If we look at the percentage of people here, over 80% of patients with nervous system tumors, which includes brain tumors, had some sort of physical medicine problems. So that's a large percentage, and if you look at all the other graphs compared to every other cancer, it was the highest percentage of problems compared to any other disease or cancer type. So some people would say 1978, that was a long time ago. We've become much better at healing patients and not causing as much damage. But if we look forward and moving forward to 2001, there was another study that looked at 51 adult patients with brain tumor diagnoses. And we can see it was a mix of glioblastoma, meningioma, and some metastatic brain tumors. As I mentioned before, those are some of the more common ones. The most common deficits, and these are percentage of the patients of these 51 patients that had these. Impaired cognition, which means thinking. 80% of patients had impaired cognition. 78% had some sort of weakness. Over 50% had a visual perceptual deficit, and that goes with kind of our coordination or how we're seeing things. And if we look at the bottom, what I highlight, showing that it is still quite a problem, is almost 75% had 3 or more concurrent neurologic deficits. So that means 3 or more of these plus some other ones. And actually almost 40% had 5 or more deficits. So clearly, despite us getting better at treating in 2001, there were still significant functional impairments that we're seeing in this patient population. Moving forward again to 2012, there was another study that evaluated fatigue in 25 brain tumor patients after surgery that came into a rehabilitation unit. So after they had surgery, they left the hospital and went to a rehabilitation facility to continue care. And what they found was 84% of the patients reported fatigue over the previous week. So again, a large percentage of these patients are affected by fatigue, which is a common impairment that we see in all cancer types, but can significantly impair all aspects of function. And the other part I think is helpful to highlight this is insomnia was an independent significant predictor of fatigue. So commonly, whether it's pain or because of steroids or other treatment aspects, sometimes the difficulties with sleeping led to some of that. But those are impairments that are important for us to manage and treat as well. Moving forward, in 2013, this was from the Journal of Neuro-Oncology. So there was a recognition in the cancer and the medical and neuro-oncology community that they looked at 147 patients who had brain tumors in Italy, and they evaluated for thinking, and that's the cognitive impairments. For them, these are outpatients, so people who weren't sick enough to be in the hospital but were getting care at home. There was over 50% demonstrated some sort of thinking impairment. And as we talked about multiple types of impairments, over 45% had multi-domain impairments. And as you can see, this next part of the slide, types of domains we speak of when we think of cognition is language, attention, memory, how fast we're thinking, which is processing speed. They did notice older patients had higher cognitive deficits, and those who received chemotherapy, as well as those who the tumor affected the left side of their brain. Some of those make sense in terms of how we understand brain function, but I think it's still helpful for us to associate as we learn more about what types of patients may be at higher risk for some of these deficits, so we can pay attention to it earlier and sooner and intervene. Other types of functional issues that we pay attention to are not unique to brain tumor patients, but they're seen in many patients that we know we can help treat with various services, and that includes pain, weakness. Mobility loss means difficulty moving around. ADL speaks of activities of daily living, and that includes bathing and dressing and doing our normal hygiene. Cognition, we spoke about. Communication sometimes rolls into that, but sometimes that just has to do with speech. Swallowing difficulties or ability to tolerate nutrition and hydration. Bowel, bladder, and sexual dysfunction, which sometimes gets missed when we're so busy with the medical care, but is often an important part of many people's lives and relationships. Looking at the skin, whether that's related to the scalp or other issues as a side effect of treatment. Looking at that psychosocial model, so we pay attention to their social supports and their not only just depression, but anxiety and other mood-related issues that can come and go during the treatment course, as well as vocational and economic concerns. Obviously, we've always focused on the patient, and we focus on treating the disease and treating their function. But as we mentioned, there's the other surrounding environmental pieces about stresses from job or finances that can affect the plan we need to put in place. What I highlight in this next part is something called deconditioning. It's something I speak about to all the medical students I interact with, the residents or doctors in training, other physicians. Every time I speak of cancer rehabilitation, I think this is something I want to highlight. And really it is a cumulative multifactorial phenomenon. It results in a functional decline due to changes in multiple body systems. So some people may have heard the term deconditioning and think of just I'm in bed or I get sick and I'm not moving around and I'm just kind of out of shape. But it really affects a lot more than that. I could spend hours speaking about this, but I think highlighting some important factors about where we're going to move to next is important because deconditioning has these effects in absence of disease. So this is just if we went in bed rest, whether I had a brain tumor or I'm undergoing chemo or radiation, this is an absence of that. So if I was on bed rest, there's been studies that show we can lose 5 to 10% of muscle mass per week. Complete immobility, you can lose 1 to 3% strength per day. After being in the bed for 3 weeks, which some patients may be due to surgery or being ill, a resting heart rate can increase by 10 to 12 beats per minute. So sometimes people have a fast heart rate, again, just from being inactive. There is some evidence to show that just doing some activity, and they talk about contraction per day, 50% of your maximal strength, so that means just getting up and using your muscles and really squeezing them, is enough to help prevent some of this muscle decrease in the body from declining. Deconditioning can also cause sensory deprivation, depression, and social isolation, as well as decreased pain tolerance. We normally don't think about how it can decrease our pain tolerance, but sometimes just not moving, our body gets hypersensitive to certain issues, and other things may flare up. And that's, again, an absence of any disease or cancer treatment. Another part that is important to pay attention to is cancer-related fatigue. As I mentioned, it's been shown that many patients who go through cancer treatment related to brain tumors can have fatigue. Cancer-related fatigue is a little different than regular fatigue. The key component is it is not relieved by rest. Some days we don't sleep well, we're tired, we get a good night's sleep, and we feel better. That doesn't dismiss that fatigue, but it's different than cancer-related fatigue. The other part that is important is the different ways it may present. And if you look at the slide, you can see how it may present outside of just being tired. The examples I give in terms of how to pay attention is if anyone has interacted with children or young children, sometimes when they're tired and we say they need a nap, you may see a lot of these issues, such as diminished concentration or attention, this marked emotional reactivity, so they may be irritable, they may not remember things. People may actually be, may have insomnia related to fatigue, because they may be physically tired, but they just can't fall asleep. You may have some of this decreased motivation. So again, it's not just tiredness, and they may present in different ways. Things that can affect this aspect of cancer-related fatigue. I break this slide up really in two aspects. We can look at this side here on the left, separate from this side here on the right. The side on the left are what I usually tell people are things I can't control. Generally, people that come to see me for rehabilitation, they have a brain tumor or they have a cancer. There's sometimes effects on the tumor that I can't control. They have that diagnosis. They're often getting chemotherapy, and sometimes there's direct effects of the chemotherapy that cause them to have effects such as related to fatigue, or indirect effects. It can cause problems with the heart or your hormones, such as your thyroid. It can make you feel depressed. But those are parts I can't change. Again, it's part of the treatment for the tumor. Again, related to hormonal therapy or radiation or other medications, such as seizure meds, which may be able to cause some of those fatigue or issues related to that. I apologize, this word anemia should be on this side in terms of the spacing, but if I look at from anemia and this list down, I look at this part of things I can control. So in terms of anemia, which is low blood counts, sometimes we supplement people with vitamins or iron, or sometimes they need a transfusion. We can look at sleep hygiene or medications to affect their sleep. Some people have sleep apnea where we get a sleep test and they may benefit from a CPAP or a BiPAP machine to help people sleep. Poor nutrition, and I should have this as hydration as well. So try to work on things to build up appetite and make sure they have the calories. Depression includes other mood aspects, including anxiety, that sometimes with therapy or seeing a counselor or with medications, we can help that. And immobility and pain are a little more directly that people view as rehabilitation of getting people up and moving. So as I mentioned, immobility relates to deconditioning and can cause pain. All those things can make us tired. So anytime where we're looking at that, I'll look at, again, the things I can't control versus the things I can control when we set up a program. So how do we help is really the next step. I've identified a bunch of issues that we may see and impairments, but really, how do we know what rehabilitation does? Is it helpful for the patients or their families? So luckily, through my training at my current location and my experience here thus far, a lot of my partners and colleagues have done some of this research at my current institute, where we look at and evaluate the benefits of rehabilitation in patients with brain tumors. My colleague, Dr. Marciniak, back in 1996, did a review of 159 cancer patients over the course of rehabilitation here at our institute. And 72% of those 159, so nearing about 50%, were brain tumor patients. And what she found was patients with cancer of all types, even those with cancer that spread or metastatic disease, made significant improvement in functional status during their course. So why this study was important is, and even now, we fight the battle of insurance companies or even other doctors questioning whether cancer patients or brain tumor patients should come and benefit from rehabilitation services, given that cancer is a serious diagnosis and they may be getting treatment, and whether rehabilitation is worthwhile for them. So this study absolutely showed that cancer of all types, no matter how spread it was, tended to make functional improvement. And her study actually showed that patients who were receiving radiation tended to do better than those who were not receiving radiation or actually got radiation before rehabilitation. I don't have a great explanation for that, but it did show even patients going through treatment did well. There was another study done at MD Anderson that demonstrated similar FIM efficiency between low-grade and high-grade astrocytomas. So let me explain that. So FIM efficiencies means the progress or the speed at which people recovered and improved in rehabilitation. So our FIM is a scale that we use to judge how much help someone needs. And when we talk about low-grade and high-grade, those are patients with a lower-grade tumor, such as maybe a meningioma, or a higher-grade astrocytoma is when we talk about grade 3s and 4s. So this is low grades are 1s and 2s and 3s and 4s. So despite the type of cancers we talked about, both populations tended to do well in this process. We've had multiple other studies that show if patients with brain tumors made gains comparable to patients who've had strokes, and TBI means traumatic brain injuries. So as I mentioned in the beginning, we know patients with strokes and traumatic brain injuries, they come to rehabilitation all the time. That's something that's accepted. We needed to prove this, that patients with brain tumors can make similar gains when their brain is affected, although in a different way, with rehabilitation. And again, another study from some of the colleagues back in 2001 and 2005 showed that the etiology, which means the cause of the brain injury, is not a significant factor in how well they do. So whether it's a stroke or a tumor or surgery or a gunshot, patients, the cause didn't make that difference, and all patients would benefit. Moving on to outpatient rehabilitation, where a lot of patients often are. They're not often in the hospital. They may have the hospital as part of their course. We have a lot more limited studies. There was a small study, and as you can see, only 10 patients that they looked at, and they had a 1-month and 3-month follow-up after they left the inpatient. And these patients showed functional improvement up to these 3 months. So they were in the rehab hospital, and then they went home, and they continued to get better. There was a study that looked at an outpatient traumatic brain injury rehabilitation program. So these are patients who, whether it was a car accident or another type of injury, had a traumatic injury to their brain, and they applied that program to patients who had a primary brain tumor. They put 13 patients through, and they found improvement in their function and their work productivity, and they maintained their gains from an average of 8 months post-discharge. Again, more evidence that shows patients who have this type of injury would benefit. And another type of therapy where you didn't go to a facility, but a home neurorehabilitation program. When we mean by neurorehabilitation, that means rehabilitation that functions to improve patients that have effects to their nervous system, such as their brain or the spinal cord. And they looked at a group of malignant brain tumors, and they had improvement of function in about 1/3 of patients. So this was just a program of at home. So they didn't go to a facility, and about 1/3 of them still benefited. When we look at types of therapy for cognitive dysfunction, and that's the thinking function that we talked about, there's a lot of inconclusive evidence for various interventions. Some of the challenges is, as we mentioned, the types of problems with thinking. Sometimes it's due to the tumor, sometimes it's due to medication, sometimes it's due to other aspects, and there's variable causes and variable severity. It's difficult to manage and do a study when there's such variability. Things that we do use clinically, though, include medications, and that includes modafinil, which is also known as Provigil. There's a newer medication called Nuvigil that some physicians do use. Methylphenidate can be known as Ritalin. It's a stimulant. Donepezil is one medicine they often use that some patients may have heard of related to dementia. And we talk about dopamine agonists. So those are medicines that increase the dopamine supply in the brain, and they may help the brain kind of click and function. We generally call these types of medications neurostimulation, and that means we're trying to stimulate the brain to help recover. And outside of medications, we have our speech-language pathologists who don't just focus on speech, but they focus on cognitive therapy. And that's in essence exercise for the brain. And sometimes that's the main focus that we do for anyone who has cognitive dysfunction to help us assess the plan. When we talk about exercise, this is my favorite part of the talk, and the thing I highlight most to all the patients I interact with is exercise interventions. No one argues or has any concerns about the benefits of exercises for our cardiovascular health, which is our heart and our blood vessels, our pulmonary or lung health, endocrine, and that means patients with diabetes or other hormonal problems, neurologic, as we mentioned, people with strokes or Parkinson's, they often get exercise. Our well-being and psychologic, there's been multiple studies that show as we exercise, we tend to feel better, as well as quality of life. But what does this mean for our brain tumor population? Well, the American Cancer Society doesn't differentiate between different types of cancer diagnoses. They do recommend, in order to see a protective effect in terms of the benefits, they recommend at least 150 minutes of moderate intensity weekly exercise or 75 minutes of vigorous intensity activity weekly. So when we look at this, this is often a challenge and intimidating to people who look at these numbers and they say, there's no way I can get that. I self-admit I struggle to meet oftentimes these activity numbers. But what I want to highlight is the goal is to reach those numbers, but just because we don't reach those numbers does not mean we don't get a benefit from those numbers. And I'll talk more about that in the upcoming slides. So another way to highlight the benefits of exercise, if we look here in the upper left, here's a normal cell, and over here in the bottom right, there's a neoplastic cell, which means a cancer cell. There's multiple steps that takes for our body to have some difficulties for this normal cell to become neoplastic. If you look at this chart, and you don't have to pay attention to the details, but within these steps, cancer can develop, and exercise has been shown to prevent some of these changes from happening from normal to neoplastic. And that's, in essence, what this next slide describes. It's been shown to alter these specific pathways of tumor initiation, that means the start of it, and carcinogenesis, which means the development of cancer. We might hear those terms with not having certain chemicals in our environment that they can cause cancer. So things can cause, but also things can prevent. And exercise has been shown to alter some of these specific pathways. They may exert a preventative effect by dampening these processes based off those little markers I showed in this previous slide. So again, you don't have to pay attention to the details. I wanted to present it to you so you at least see the information, but this is kind of the important idea of why I emphasize exercise. So when we talk about exercise and how it can help us outside of that important detail when we're looking at the microscopic level, when we look at cancer-related fatigue, there was studies of 32 cancer patients with mild to severe fatigue during and after chemotherapy, and they did 3 weeks of aerobic and resistance training program or an exercise program. And after 3 weeks, they had a 25% reduction in their global fatigue, which is pretty good. So if we talk about most medications that come to the FDA and get approved, if they have 25%, they're going to be scoping through, and most people are going to be buying that right up. But this is just exercise. No medications, no fancy tricks. It's just getting people up and moving. Other things that we do to treat this outside of just exercise, I had mentioned these medications, some of these medications for neurostimulation, as well as steroids or antidepressants. We use some of the cognitive behavioral therapy, even though we don't think of fatigue as thinking problem. As I mentioned to you in the other slides, sometimes it can affect our thinking, so changing our brain processes. Looking at sleep hygiene, and again, and energy conserving techniques. And I often get questions as, what are energy conserving techniques? It can start as simple as teaching people body mechanics, how to move in and out of bed, how to stand, how to sit, how to help themselves dress them, put on their socks and shoes without struggling. And sometimes we talk about equipment or adaptive aids to help them. A simple example that we often use is oftentimes people may have difficulty getting their socks and shoes on. There are some tools, and one is called a sock aid that helps people get their socks on, or a shoehorn. And oftentimes people get these small shoehorns that they have to lean down anyway. It can be as simple as getting what we call a long-handled shoehorn that allows people not to struggle to produce that process, and it saves their energy to do other activities. And again, to add on to exercise, we often talk from a medical standpoint of cardiopulmonary fitness. And that just in essence means our general fitness level. Some of you may have seen some of the commercials where people, for instance, a sports drink brand where they're wearing a mask on a treadmill and they're measuring all these, they have all these monitors. What they're really in essence highlighting in that commercial is measuring this peak oxygen consumption. So the mask is measuring how they're breathing and how they're using oxygen. This fitness level of how well we're able to use oxygen is a key predictor for mortality in all populations. So this is whether you have cancer, whether you don't have any medical problems, whether you have heart disease or kidney problems. There has been a lot of research in our cardiac population and our cardiologists who are assessing the heart often, that if you have a 12% improvement in survival for men and a reduction in death by 70% in women for every 1 MET increase in aerobic capacity. So what does 1 MET equal? And as you see up here, so 1 metabolic equivalent equals this fancy formula, but a simple way to think about it is our body's always expending energy. So just sitting here, if we're sitting at our desks right now or at a table listening to this, we're expending about 1 metabolic equivalent. So our body takes a baseline amount of energy. If we're walking at a fairly brisk pace, not slow enough where we can read a magazine and not fast enough where we're jogging and huffing and puffing, but a slow enough pace, that's about a 3 metabolic equivalent activity. You could often just search on the internet and look up these metabolic equivalents with different activities, and you can find how they're rated. Obviously, they're a little generalized, but the fair bet is usually about 1 metabolic equivalent when we're sitting. A brisk walk is about 3 metabolic equivalents. And in the breast cancer population, it's been shown, and unfortunately we don't have this data yet in our brain tumor population, is patients who are survivors of breast cancer, they had a 21% lower cardiopulmonary fitness than age-matched healthy sedentary women. So it wasn't compared to women who are running marathons every week. It's just people of their age group who are sedentary, not very active. So just the fact that they had treatment of cancer, we do know it can affect our heart and our fitness level. So when we talk about exercise and function, I think these next few studies are important for us to pay attention and bring home some of my final points, and hopefully we can move forward to the questions soon after. So this study here looked over a total of 544 patients over 10 years, and you can see that the time frame from 96 to 2006. And they looked at patients with a KPS, which are Karnofsky Performance Scale of 80 or greater. And I'm going to jump to this next slide so you can see this scale before we go forward. And the scale is a 0 to 100 scale. 100 is someone who's normal function. There's normal, no complaints. Unfortunately, 0 is people who've passed away or dead. So generally in this study, they looked at patients who are 80 or above, and 80, the low end, is normal activity with some effort and some signs or symptoms of their disease. And this is not specific to brain tumors, as often used for all types of cancer patients. So they looked at patients who were pretty well functioning. Around half of them had a subtotal resection, means not all the tumor was taken out. So subtotal is part of it, and total would be almost all of it, or all that they can see. And they found that the mean survival time of these patients were 11.6 months. Within this population, over 50% or 56% lost functional independence, and that's a KPS score less than 60. So if we go back to this slide, so over half the patients at some point continued to lose function, and that was requiring occasional assistance, but is able to care for most of his, or it should say her, personal needs. So at some point in their history, they started here and they came down to here, over 50% of them. And the median functional independence length is 10 months. So that means they were doing okay for a majority of their care, but maybe towards the end, given that the survival time was 11.6, the 10 months they started having challenges. So people who tended to have the prolonged survival or function, so if you had improved preoperative and immediate postoperative function, so that means if your function was good before surgery and right after surgery, which is considered within 1 month, it was associated with prolonged survival. The greatest survival is in patients with KPS greater than 90, so that's near the top of the scale. And they found that the post-op function was a stronger correlation than pre-op status. So that means how they came after surgery within that 1 month was more predictive than how people were before surgery. Why I highlight that part is if we pay attention to function, as I mentioned about rehabilitation, of why it's important to get things involved, there is this relationship with people doing better because they're functioning better. And the next study as we move through here, we'll talk more about that, but there are some other correlations with function. There's been studies that show that people who have that high functional level tend to do well with prognosis. Patients with a primary glioblastoma, and that means that glioblastoma that just came about and didn't develop from a lower grade type of tumor, people that had most of the tumor taken out, and that's the gross total. Interesting enough, people with preoperative seizures, and I don't have a good explanation of why people with preoperative seizures tended to do better, and people who are treated with temozolomide, which is also known as Temodar, is one of the oral chemotherapy agents. Things that were negatively correlated with function are people who are older at the time of surgery, which is not too surprising. People with CAD, which is heart disease, or people with a new postoperative motor deficits. So that means after surgery, they develop new weakness. So these are just correlation factors. Because someone has one or the other of an older age or heart disease does not mean they won't do well. And just because someone has, in essence, a treatment with this doesn't mean they'll always do well. But these are things that for us, when we understand what patients may go through, may help us through this process. And this last study, which is somewhat my take-home point overall, is we looked at the efficacy of exercise. This study was done in 2011 and was in the Journal of Clinical Oncology. And they looked at 243 adult patients with grade 3 or 4 malignant glioma. So these are the higher grade tumors. And they started off with this KPS of 70. So that's a decently high functioning person. They administered a questionnaire to assess people's exercise behavior, as well as doing a test of a 6-minute walk test, which basically just monitors how far they walk in 6 minutes. And they followed these patients up for over 2 years. This first slide shows that 6-minute walk test and the survival time you see of how people survived. And these are in meters, so you don't have to pay attention to how the cutoffs are. As you can see, most of these lines are pretty symmetric. So people that walked under 390 meters or people that walked almost 500 meters on this test, there was no difference in survival that they found over this course. What was important is based off that self-assessment of exercise, is people that exercise over 9 MET hours per week was associated with a median survival of 21.84 months. People that exercise less than 9 MET hours per week was associated with a median survival of 13.03 months. When I look at that, it's a pretty significant difference. And just to highlight, it is not a cause and effect. It is a correlation because they've kind of just monitored. They didn't do exercise as an intervention. But it does show us that patients' ability or exercise behavior, not necessarily their capacity of function, was important in terms of survival. So moving forward through the spectrum is, from a physiatrist end, I want to look at my patients. I want to improve their function and improve their fatigue and improve their symptoms that are limiting their exercise so I can allow them to exercise. So hopefully we can think about this effect, improving survival, improving their ability to manage treatment to improve that part. So it's not just quality of life and doing what you need to do, which is important, but hopefully as we get more data, we may see more benefits of exercise actually changing survival. And I know I mistakenly did not clarify the MET hours. So as I talked about before, 3 METs is a brisk walk. So if we talk about MET hours, it's hours that we do the MET activity. So a brisk walk, which is 3 METs for 3 hours, is 9 METs. So 3 times 3 is 9. So we can look at the different activities, and that's usually where we start getting people to move up and up and trying to get that brisk walk and just get people moving to build up so we can build this activity end. The challenge that we often face is not just those symptoms, but often people's perceptions of their ability to exercise. So there was a study that showed they interviewed 106 brain tumor survivors and had them complete a questionnaire on their exercise behavior over 75% had these grade 3 or 4 disease. 47% of patients or survivors perceive themselves as able to exercise during treatment. So that's under half of the patients only thought they can exercise during treatment, and only 45% wanted information about exercise during treatment. The numbers did increase afterwards, but if we kind of highlight what I've just mentioned in the last few slides, and I talked about rehabilitation, I talked about exercise, from my end, if possible, I'd like to get involved early and often to build people up and not just wait till we're done to get started. So the next steps is engaging patients, families, friends, medical personnel to take further interest in active roles in rehabilitation and exercise, determine consistent measures to track these outcomes and issues, so how we can determine how patients are having symptoms and how we can intervene, and change that culture. So we change, moving through here, these under 50% of people thinking they can be involved or even interested in being involved, to over 50%, and then hopefully 75%, and then hopefully everyone is getting part of their care, and it's just as important as their care as any other part. So obviously I'm biased as a rehabilitation doctor, but that's my perspective, and I think this is the end slide of a disclaimer, and I think we should be ready for questions, Antoinette.
Yes, thank you, Dr. Shahpar. That was a great presentation. We'll go ahead and move into our question and answer segment. And if you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. So let's see. Do you know if any NCI designated cancer centers are required to have physiatrists on staff?
So currently, in terms of the requirement, with the American College of Surgeons actually certifies many of the cancer centers, and several years ago they came out and required cancer centers to require rehabilitation care. They did not identify specifically a physiatrist. It could be a therapist, it could be a variety of professionals that they identified as rehabilitation. So it does vary quite a bit. I can say a lot of the centers do have physiatrists involved, at least peripherally, that can be part of patients' care. The challenge is sometimes the oncologists themselves aren't aware of some of the benefits that we can offer. So there's no requirement for a physiatrist involved. There is to be a certified cancer center, there is a requirement for some sort of rehabilitation services. From my end, we're pushing for more coordinated physiatrist-led rehabilitation, but that's still developing.
Thank you. I have another question. Where would a neuropsychologist fit in the treatment team?
So the neuropsychologist, if I sometimes have more time, we delve into that a little bit more. We as physiatrists, we do use neuropsychologists, and sometimes our oncology team members do as well. What a neuropsychologist helps to do is they're trained in with a psychology background with a fellowship in this neuropsychology, and they really do extensive cognitive testing. They really interview the patient, get to know them, their education, and as I mentioned, those domains of thinking, language, processing, attention, memory, they do specific tests, and these tests can sometimes, the total of full neuropsych testing can last maybe even 4 hours to really break down and tease where those deficits in thinking are. So sometimes if we have a difficult time assessing that, or we want more details regarding someone going back to work or making certain decisions or really just having a challenge, we sometimes do the neuropsych testing to give us that extra detail. Our speech therapists sometimes do bits and pieces without doing the whole neuropsychology, but we definitely utilize them pretty frequently. The challenge that sometimes we face is, as an outpatient, sometimes insurance coverage of that can be limited.
Okay, thank you so much for that answer. And we do have a question, like, what is the difference between home versus outpatient rehab programs?
So when we speak of the settings of rehab programs, generally when we talk about home programs, that means someone comes to the person's physical home. So they don't leave the home to exercise, whether a therapist comes into the home and works within the home environment. Outpatient is generally considered going to a facility. So if you go to a gym or a hospital where they have their equipment there and you're meeting the therapist, for instance, like an appointment. So that's really the distinction there. Oftentimes with home health services where we get that, people who have difficulties getting into the house or don't have support or transportation, we may start with home or do home therapies before we transition to an outpatient therapy when it's easier for them to get back and forth.
Great. In your experience, which brain tumor-related impairments respond well to rehabilitation and which respond poorly?
So globally speaking, I've seen benefits in all types of impairments with rehabilitation. I've been seeing patients with brain tumors for a pretty extensive period of time with a wide variety of where it is. I would say the one part that would be probably most challenging is people that have cerebellar dysfunction, and that's a part of our brain in the back of our brain that often affects coordination, balance, and sometimes can cause dizziness, and also some of the visual stuff that goes along because obviously the coordination. That's not just related to brain tumors, even people who've had strokes or an injury to their cerebellum otherwise, sometimes that's a challenge to have rehabilitation interventions. Do we get some people better with rehabilitation? Absolutely, with cerebellar problems. But when we're just talking about weakness or some thinking problems, the cerebellar difficulties tend to be the most challenging.
Thank you. Do you have any suggestions for insomnia?
So that is somewhat of a loaded question because there's so many different factors that can affect insomnia. And starting off with when I mentioned the things I can and can't change. Sometimes it can be related to just the medications and the treatment. One common piece we use, and I just had the patient the other day, patients sometimes are on steroids, and sometimes the steroids are twice a day or multiple times a day. We sometimes move the steroid to make sure it's not given too late at night. For instance, if people are taking it at 8 o'clock, it can be stimulating. If we take it closer to dinner time, they may be able to sleep better. Otherwise, we can talk about sleep hygiene and how they're sleeping in general. A common question, if anyone comes with insomnia, I always ask, do they snore? Do they nap? Do they feel rested in the morning? Sometimes they talk about difficulty sleeping even before their treatment. For those patients, we often talk to their primary care doctor and maybe do a sleep study and hopefully treat maybe they have a primary sleep problem unrelated to the treatment. And then sleep hygiene, some basic things to talk about. And most people might have heard this in the news or otherwise, is no TVs, no reading in bed, get off the phone when you're in bed. We don't want things while we're in bed to stimulate us. And that includes eating and TV and reading. When we go to bed, bed is our place to sleep. If we do other things in bed, our body gets used to doing other things in bed. So when we go in there, we still become stimulated. And the last part, if we can't control those external factors, there are medications we can use depending on what's going on with the person medically to look at. But there's things non-medication wise in terms of medication specifically for sleep that we can assess first before we just start jumping and adding more medications to someone's regimen.
Thank you. To what extent do diet and nutrition have an impact on rehabilitation efforts?
So I will preface that I am not an expert in diets or nutrition. I'm not a dietitian. My expertise comes from my medical background, so we have some interest, but I do, from specific questions about diet and nutrition, I often defer to our experts from that end. What I can say is we need calories and water and hydration to function. If we don't have enough calories and hydration, our body will fatigue and not function. When I'm in Chicago, and even though our winters can be cold, our summers can be quite hot. And if someone is out in the heat, they can have difficulties with just being hot and sweaty. And I say sometimes we get hydrated and we feel better. So some simple activities of making sure we're staying hydrated throughout the day and drinking water if appropriate and medically appropriate, and there's no restrictions, as well as making sure you get steady calories throughout the day in order to make sure our motor continues to run as we're dealing with not only the cancer and cancer treatments, as well as our recovery and exercise that we want to do. So I talk to all my patients about that. If we need further details, I may refer them specifically to a nutritionist or a dietitian, but we kind of start with the basics. If they're not drinking much throughout the day, we just start with drinking. If they're not eating enough calories, then we start with making sure they're getting those calories in their system.
Thank you. And we do actually have a webinar coming up next month on diet and nutrition for brain tumor patients. with a registered dietitian giving that. So I'll talk more about that later at the end. I do have...
Perfect.
Go ahead.
I know I was saying that's a perfect transition.
Oh, yes, definitely. I do have time for one last question. Does the insurance cover rehabilitation programs?
So rehabilitation is part of everyone's insurance program if they have from basic standard, including Medicaid and Medicare. The rehabilitation benefits do vary quite significantly. And sometimes it's split up in ways that don't necessarily make common sense. Most rehabilitation facilities should have people to help you work through that process regarding how much benefits you have in terms of how many sessions or how much money within your insurance needs to go through. So if you have interest or you're seeing a physiatrist or even your oncologist, even just writing the referral for therapy or to see someone can help stimulate that process, or obviously being your own advocate and talking to your insurance company. But all of the patients that I see, we work through insurance primarily.
Great. Thank you so much, Dr. Shahpar. That is all the time we have for today. And again, we want to thank everyone else for joining us and Dr. Shahpar for his wonderful webinar presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line, which is staffed by caring professionals, at 800-886-2282. Let's pause for just a moment to conclude our webinar recording.